Welcome back, everyone, to another deep dive. You know, we always go for those really complex topics, and this time is no different. We're diving into the world of pineal region tumors.
It's a fascinating area, really.
Oh, absolutely. And I know our listeners, you guys are out there really trying to wrap your heads around this stuff
Yeah.
and, avoiding all that dense medical jargon.
hmm
That's kind of what we're all about here, getting right to those key insights.
Exactly. We want to make this journey through the medical literature as accessible as possible, pulling out the most relevant points about pineal region tumors, their pathophysiology, and the current management strategies.
You know, sometimes I'm just amazed by how much can go wrong in such a tiny part of the brain.
Oh, it's remarkable, the diversity of issues that can crop up in this region.
It is.
We're talking about both neoplastic and non-neoplastic lesions, a whole spectrum of possibilities.
Right. And just to give everyone a clearer picture, let's sort of map out this pineal region, anatomically speaking.
Sure.
So imagine the very back of your brain. Tucked in there is this pineal region, bordered by, well, a bunch of important structures.
Yeah.
Dorsally, you've got the splenium of the corpus callosum and the telechoroidea. Ventrally, it's the quadrigeminal plate and the midbrain tectum. Rostrally, it's kind of near the posterior aspect of the third ventricle.
Right.
And caudally, you've got the cerebellar vermis. It's a really compact area with a lot going on.
It really is, and it's astounding how this small area can give rise to so many different types of lesions. The research actually shows that over 17 different tumor types have been identified in the pineal region alone.
Wow, 17 different types. That's incredible for such a small space.
It's amazing, and it also kind of highlights the challenge in diagnosing these tumors accurately.
Yeah, exactly.
So that's precisely what we're aiming to unpack today.
Right.
We want to shed light on the key characteristics of these tumors, how they present clinically, and the strategies doctors use to manage them.
Absolutely. We're going to try to make sense of all this complexity, providing a clear and concise understanding without getting lost in the weeds. All right, let's dive in. First off, who is most likely to be affected by these pineal region tumors? Is there a specific age group that's more susceptible?
What's interesting is that there's a noticeable difference in prevalence between children and adults. Pineal region tumors are significantly more common in children, accounting for about 3 to 8% of all pediatric brain tumors. In adults, however, they're much less common, representing less than 1% of brain tumors.
So a significant difference there. Now, if we focus on children, are there specific types of tumors that are more frequently seen?
Yes, when we look at the pediatric population, those under 18 years old, germinoma is the most common type. One study found that out of 36 cases, 11 were germinomas. Astrocytoma was also fairly common in this group, with 7 out of the 36 cases. But what's really intriguing is that the remaining 18 cases represented 15 different tumor types.
15 different types in just 18 cases. That's remarkable diversity.
It really is, and it emphasizes how diverse these tumors can be, especially in children. It makes diagnosis quite challenging sometimes.
Absolutely. Now, what about adults? Does the pattern change as people get older?
It does. Germ cell tumors, like germinoma, and pineal cell tumors tend to occur primarily in childhood and young adulthood. So if someone is diagnosed with a pineal region tumor after the age of 40, it's more likely to be something like a meningioma or a glioma. The mean age at diagnosis for pineal region tumors overall is about 41 years.
Okay, so there's a clear shift in the types of tumors we see as age increases. Now let's delve a little deeper into these common tumor types, starting with germinoma, since you mentioned it's the most common overall. What are the hallmarks of this tumor?
Germinoma is indeed the most frequent type, accounting for 21 to 44% of cases in American and European populations. In Japan, it's even more prevalent, with an incidence of 43 to 70%. One of its key features is its tendency to spread via the CSF, leading to what are called drop metastases.
Drop metastases that paints a vivid picture of how it can spread. What are some other important tumor types we should be aware of?
Another significant one is pineoblastoma. This is a WHO grade 4th tumor, meaning it's malignant and poorly differentiated. Essentially, the cells look very different from normal brain cells and exhibit a high growth rate.
So how does that translate to what doctors see under a microscope?
When you look at a sample of pineoblastoma under a microscope, you'll see small, immature neuroepithelial cells. They have a high nuclear to cytoplasm ratio, meaning the nucleus of the cell is large compared to the rest of it. They also have a high Chi-67 index, which is a measure of how quickly the cells are dividing. A Chi-67 index above 20%, which is common in pineoblastoma, indicates a rapidly growing tumor.
I see. And what's the prevalence of pineoblastoma in the pineal region?
Pineoblastoma represents about 35% of pineal gland tumors, and the average age of diagnosis is younger for pineoblastoma, around 17.8 years.
And how does this aggressive nature affect the clinical course and prognosis for patients with pineoblastoma?
Unfortunately, pineoblastoma is known for its aggressive clinical course and a high rate of CSF metastases. The prognosis can vary quite a bit. Median survival times range from 4.1 to 8.7 years, and the 5-year survival rate can be anywhere from 10 to 81%.
So, a wide range of potential outcomes. Are there any factors that are linked to a poorer prognosis?
Yes, several factors can influence the outcome. The presence of disseminated disease at diagnosis, meaning the tumor has already spread, is a negative prognostic factor. Younger age at diagnosis is also associated with a less favorable outcome. And if surgeons aren't able to remove the entire tumor, the prognosis tends to be worse.
It sounds like early detection and complete surgical resection are crucial for improving outcomes in pineoblastoma.
Absolutely. And radiation therapy plays an important role as an adjuvant therapy, meaning it's given after surgery to help kill any remaining tumor cells.
Makes sense, given its aggressive nature. Now let's move on to pineocytoma, which seems to be a different beast altogether.
Yes, pineocytoma is quite a contrast to pineoblastoma. It's a WHO grade eye tumor, so it's much less aggressive and is considered benign. It's also much rarer than pineoblastoma and typically affects adults. The average age at diagnosis is around 43 years.
What about its appearance under the microscope? What makes pineocytoma distinct?
When you examine pineocytoma under a microscope, you'll see these characteristic structures called pineocytomatous rosettes. It's a key distinguishing feature. And unlike pineoblastoma, pineocytoma is typically confined to the pineal gland itself. It doesn't tend to spread or infiltrate surrounding tissues.
That's reassuring. And what about the prognosis for patients with pineocytoma?
The prognosis for pineocytoma is very good. The 5-year survival rate is high, ranging from 86 to 91%.
That's fantastic news. Now, we also have pineal parenchymal tumor of intermediate differentiation. How does that fit into the picture?
As the name suggests, this tumor type falls somewhere in between pineocytoma and pineoblastoma in terms of its malignancy. It's not as aggressive as pineoblastoma, but it's not as benign as pineocytoma. Its clinical and biological behavior can vary quite a bit.
So it occupies a kind of middle ground. What are its microscopic features?
It's composed of monomorphic round cells that appear more differentiated than pineoblastoma cells.
And how do doctors classify its malignancy?
The biological behavior of pineal parenchymal tumor of intermediate differentiation can range from WHO grade 2 to WHO grade 3.
Okay, so its aggressiveness can vary. We also have the papillary tumor of the pineal region. What can you tell us about that one?
Papillary tumor of the pineal region is a neuroepithelial tumor that typically affects both children and adults. It's characterized by a mixture of papillary and solid areas when viewed under a microscope.
What about the cells themselves?
The cells have an epithelial-like appearance and often show immunoreactivity for cytokeratins, particularly CK18.
So what's the typical age of diagnosis for this tumor?
The mean age at diagnosis is around 35 years.
And what about its behavior? Does it tend to spread?
It's known to recur, meaning it can come back after treatment, but spinal metastases are rare. The 5-year and 10-year survival rates are pretty good, around 73%.
That's encouraging. Is there anything else noteworthy about this tumor type?
It's worth mentioning that the histological criteria for grading the malignancy of papillary tumor of the pineal region are not yet well defined.
So there's still some work to be done in terms of fully understanding its behavior.
Right.
Now, our sources also point out that many pineal region tumors can be of mixed cell type.
Yes, that's an important point to remember.
That must really complicate things in terms of diagnosis and treatment.
Absolutely. The presence of multiple cell types within a single tumor can make it much more difficult to classify and determine the best course of treatment. It underscores the need for careful examination of the tissue sample and potentially the use of advanced diagnostic techniques.
Okay, moving on from the different types, let's talk about how these tumors actually manifest. What are the typical symptoms that might signal a problem in the pineal region?
Well, the symptoms can vary depending on the specific type of tumor and its location, but some common clinical features are seen in many cases.
Okay, what are those?
One of the most frequent presentations is hydrocephalus. It's seen in almost all patients with pineal region tumors.
And just to remind our listeners, hydrocephalus is a buildup of fluid in the brain.
Exactly. It's often caused by the tumor blocking the normal flow of CSF. This blockage leads to increased pressure within the skull, which can cause a variety of symptoms.
What are some of the common symptoms of hydrocephalus?
The classic triad of symptoms includes headache, vomiting, and papilledema, which is swelling of the optic nerve. Other symptoms can include lethargy, memory problems, and even seizures. In infants, an enlarging head circumference is a red flag.
It sounds like those symptoms can be quite general. Are there any more specific signs that might point to a pineal region tumor?
Yes, there are some specific signs that can be particularly suggestive. One is Pineal syndrome.
And what is that exactly?
It's a cluster of eye movement abnormalities that can occur when there's pressure on certain areas of the brain, particularly in the pineal region.
Okay, what kind of eye movement problems are we talking about?
Patients with Pineal syndrome might experience difficulty looking upward, have problems with convergence, where the eyes can't focus together on a near object, and they might have pupils that don't react normally to light.
Interesting. So eye movement issues can be a clue. What about hormonal effects? Can pineal region tumors cause hormonal imbalances?
They can, especially certain types. For instance, some germ cell tumors, particularly those that contain syncytial cells, can secrete a hormone called beta-HCG.
And why is that significant?
Beta-HCG is similar to the hormone that stimulates the testicles to produce testosterone. So in boys, these tumors can lead to precocious puberty.
Precocious puberty, meaning they start going through puberty much earlier than expected.
And it's
That's a fascinating hormonal connection. Are there any other hormonal effects we should be aware of?
Yes, germ cell tumors that are located in the suprasellar region just above the pineal gland can sometimes cause a triad of symptoms: diabetes insipidus, visual disturbances, and panhypopituitarism.
Okay, let's break that down a little. Diabetes insipidus, that's not the same as diabetes mellitus, right?
No, it's a different condition. Diabetes insipidus affects the body's ability to regulate fluids. It can lead to excessive thirst and urination.
And what about panhypopituitarism?
Panhypopituitarism means that the pituitary gland, which is a master gland that controls many other hormones in the body, isn't functioning properly.
So it can lead to a whole cascade of hormonal issues.
Right.
Now, we also talked about drop metastases, where tumor cells spread through the CSF. Can those cause specific symptoms?
Yes, they can. If tumor cells reach the spinal cord or nerve roots, they can cause problems like radiculopathy or myelopathy.
And what are the symptoms of those conditions?
Radiculopathy is characterized by pain, numbness, tingling, or weakness that radiates along the path of a nerve. Myelopathy affects the spinal cord itself and can cause weakness, sensory disturbances, and even problems with bowel or bladder control.
So the potential symptoms are quite varied, ranging from general signs of increased intracranial pressure to very specific hormonal and neurological effects.
Exactly. And the exact presentation will depend on the type of tumor, its size, and where it's located in the pineal region.
All right, let's shift gears now and talk about how these tumors are managed. I understand the approach has evolved over time, particularly regarding the use of radiation.
You're right. There have been some significant changes in the way we approach these tumors. In the past, it was common practice to give patients with suspected germinomas a test dose of radiation therapy.
A test dose. What was the rationale behind that?
The idea was that germinomas are very sensitive to radiation. So if the tumor shrank after this small dose, it would essentially confirm the diagnosis and guide further treatment.
But our sources suggest this approach is no longer favored.
That's correct. There are several concerns about using a test dose of radiation. First, it exposes patients to radiation unnecessarily if the tumor turns out not to be a germinoma or if it's resistant to radiation.
And radiation, as we know, can have long-term side effects.
Exactly. Second, in tumors with mixed cell types, the response to a test dose might be misleading. It might shrink partially, suggesting a germinoma, when in fact other cell types are present that might require different treatment.
So it could lead to an inaccurate diagnosis.
Right. The current consensus is that obtaining a tissue diagnosis through biopsy is crucial in almost all cases.
So a shift towards a more definitive diagnosis before committing to radiation. What's driving this change in approach?
Well, apart from the concerns about unnecessary radiation exposure, there's also the realization that a significant proportion of these tumors are either benign or radioresistant. Studies have shown that anywhere from 36 to 50% of pineal region tumors fall into this category.
That's a considerable percentage. So getting a tissue sample to determine the exact nature of the tumor is crucial for making informed treatment decisions.
Absolutely. It allows for more personalized and targeted therapy.
What are the key steps involved in the current management approach for suspected pineal region tumors?
The management typically begins with a thorough neurological exam and imaging studies, primarily MRI. The MRI helps to visualize the tumor, assess its size and location, and look for any signs of spread.
And then the next step would be a biopsy, right?
Yes, in most cases, a biopsy is the next step to obtain a tissue sample for histological analysis. The specific biopsy technique used will depend on several factors, including the tumor's location and the presence or absence of hydrocephalus.
Can you describe some of the biopsy techniques that are commonly used?
Sure, if the patient has hydrocephalus, a transventricular biopsy might be the preferred approach. This involves accessing the tumor through the ventricles in the brain. If hydrocephalus is not present, other options include an open biopsy, where a portion of the skull is removed to access the tumor, or a stereotactic biopsy, which uses imaging guidance to precisely target the tumor with a needle. Another option is KCE, computer-assisted cisternal endoscopy.
And you mentioned earlier that it's important to get a sufficiently large biopsy sample.
Yes, that's crucial, especially if there's a suspicion of mixed cell types within the tumor. A small sample might not capture the full heterogeneity of the tumor, leading to an inaccurate diagnosis.
Once the histological diagnosis is confirmed, how is the treatment plan determined?
The treatment plan will be tailored to the specific type of tumor, its grade, the patient's age, and overall health.
Let's start with germinoma, since that's the most common. What's the typical treatment approach for that?
Germinoma is highly sensitive to both radiation and chemotherapy. So the standard treatment usually involves a combination of these two modalities.
And what about other types of tumors?
For other tumors, the treatment approach can be more varied. In some cases, surgery to remove as much of the tumor as possible might be the first step, followed by adjuvant therapy like radiation or chemotherapy. However, the role and effectiveness of adjuvant therapy for some tumor types are still being studied.
What about managing the hydrocephalus that's so common with these tumors?
Managing hydrocephalus is a crucial part of the overall treatment strategy. The initial step is often to place an EVD, an external ventricular drain.
What does that do?
An EVD is a temporary tube that's inserted into the ventricles to drain the excess CSF. It helps to relieve the pressure and control the hydrocephalus. In some cases, the EVD might be all that's needed to manage the fluid buildup, but in many cases, a permanent shunt might be required.
A shunt is a device that diverts the CSF to another part of the body where it can be absorbed.
Exactly.
Now, you mentioned stereotactic surgery as a technique that can be used for both diagnosis and treatment.
Yes, stereotactic surgery can be very helpful in certain situations. It can be used to obtain a biopsy, particularly for deep-seated or difficult-to-reach tumors, and it can also be used to treat certain types of lesions, such as cysts.
What are the key advantages of stereotactic surgery?
Stereotactic procedures are minimally invasive. They involve making a small incision in the skull and using imaging guidance to precisely target the area of interest. This can lead to less pain, faster recovery times, and a lower risk of complications compared to open surgery.
But the pineal region is a very delicate area, surrounded by important structures.
That's true. Stereotactic surgery in this region does carry some risks. It's essential to have a skilled neurosurgeon who is experienced in these procedures to minimize the chances of complications.
What are some of the potential complications that can occur?
Some possible complications include bleeding, infection, damage to surrounding brain tissue, and neurological deficits. However, the overall complication rates are generally low.
Okay, and you also mentioned stereotactic radiosurgery as a treatment option.
Yes. Stereotactic radiosurgery is a form of radiation therapy that delivers highly focused beams of radiation to the tumor. It can be an effective treatment for some types of pineal region tumors.
How does it differ from conventional radiation therapy?
Unlike conventional radiation therapy, which delivers radiation to a larger area, stereotactic radiosurgery is much more precise. It targets the tumor with high doses of radiation while minimizing the exposure of surrounding healthy tissue.
So potentially fewer side effects.
Exactly.
Now, let's discuss surgical treatment for the tumor itself. You mentioned earlier that there's some debate about when open surgery is the best option.
That's right. The role of open surgery, or craniotomy, in the management of pineal region tumors is somewhat controversial. Some experts believe that open surgery to remove the tumor is the best approach for most non-germinoma tumors, while others prefer a more selective approach.
What factors influence the decision to proceed with open surgery?
The decision is based on several factors, including the type of tumor, its grade, whether it has spread, the patient's age and overall health, and the surgeon's experience and preference.
What are some of the arguments in favor of open surgery?
Proponents of open surgery argue that it allows for a more complete removal of the tumor, which can improve long-term outcomes. They also point out that it provides valuable information about the tumor's extent and can help to stage the disease accurately.
And what about the arguments against open surgery?
Those who favor a more selective approach to open surgery argue that it carries significant risks, especially in the pineal region, which is a challenging area to operate on. They also point out that some tumors, such as germinomas, respond well to radiation and chemotherapy, making open surgery unnecessary in those cases.
So it's a complex decision that needs to be made on a case-by-case basis.
Absolutely. A careful discussion of the risks and benefits of open surgery versus other treatment options is essential.
What are the different surgical approaches that can be used to access the pineal region?
There are various surgical approaches, each with its own advantages and disadvantages. The choice of approach depends on factors such as the tumor size and location, the surgeon's experience, and the patient's anatomy.
Can you describe some of the commonly used approaches?
The most commonly used approach is the midline infatentorial supracerebellar approach. This involves making an incision at the back of the head and accessing the pineal region from below the cerebellum. Another approach is the occipital transtentorial approach, which provides a wider view of the area but carries a slightly higher risk to the visual cortex. For tumors that extend into the ventricles, a transventricular approach might be used. And there are several other less common approaches, such as the lateral paramedian infatentorial approach and the paramedian infatentorial supracerebellar approach.
It sounds like navigating the anatomy of the pineal region during surgery is incredibly challenging.
It is. Surgeons need to have a detailed understanding of the intricate anatomy of this area and be extremely meticulous to avoid damaging important structures.
What are some of the key anatomical considerations?
Some of the critical structures that need to be carefully preserved during surgery include the third ventricle, the corpus callosum, the thalamus, and the quadrigeminal cistern. The deep cerebral veins that drain blood from the brain are also particularly vulnerable in this area.
Damage to any of those structures could have serious consequences.
Absolutely.
What about the typical outcomes and potential complications associated with surgery in this region?
The outcomes of surgery for pineal region tumors can vary widely depending on the type of tumor, its grade, and the extent of surgery. The overall surgical mortality rate is reported to be in the range of 5 to 10%.
So there's a significant risk involved. What are some of the common post-operative complications?
Some potential complications include new visual field deficits, epidural fluid collection, infection, and cerebellar ataxia, which is a condition that affects balance and coordination.
It's clear that managing pineal region tumors is a complex and challenging undertaking that requires a multidisciplinary approach involving neurosurgeons, radiation oncologists, neurologists, and other specialists.
Absolutely. The field is constantly evolving as we gain a better understanding of these tumors and develop new treatment strategies.
So, to sum it up, we've delved into the remarkable diversity of tumors that can arise in the pineal region, explored their clinical features, and discussed the various management options available from surgery and radiation therapy to stereotactic techniques and chemotherapy.
We've highlighted the crucial role of obtaining an accurate histological diagnosis through biopsy and emphasized the shift away from the use of test dose radiation.
We've also discussed the challenges and considerations involved in surgical management, emphasizing the intricate anatomy of this area and the need for meticulous surgical technique.
Right. And we've stressed the importance of a personalized approach to treatment, taking into account the specific characteristics of the tumor and the individual patient.
And on that note, here's a final thought for our listeners. Given the remarkable progress we've made in understanding and treating pineal region tumors, what does the future hold for this field? Will we see even more targeted and less invasive therapies? How will advancements in imaging and surgical techniques continue to shape the way we approach these complex cases? It's an exciting time for neurosurgery, with the potential for significant improvements in patient outcomes on the horizon. Thanks for joining us on this deep dive.
It's been a pleasure.